Hello, everyone, and thank you for joining us for today's training, Suicide Safer Care for Behavioral Clinicians in Primary Care Settings. I also just want to take a moment to thank our Primary Care Association partners for collaborating with us on today's webinar. My name is Rick Brown. I am the Director of Communications, Membership, and Special Initiatives with the Association of Clinicians for the Underserved, and I'll be your host for today's training. If you have any technical issues at all during today's webinar, please simply reach out to me or my colleague Jen for help. For those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help transform communities to achieve health equity for all. We do that by providing training and technical assistance, advocacy, professional education, and a host of other resources to develop and support clinicians in the healthcare community, caring for America's underserved communities. We invite you to learn more about us and membership with ACU at clinicians.org. If you're interested as well in more resources on suicide prevention for patients and providers, we really encourage you to visit our Suicide Safer Care page. Over the last 4 years, we've created a host of resources and archive trainings, and you'll find these, including fact sheets, toolkits, and much more on our program page. I'll ask Jen if she can put the link into the chat, but you can also scan the QR code, which I'll leave up for just a moment. Before we begin, I just want to go over a few quick housekeeping items. First, we will be recording the session, and we'll send you the recording and the slides a short time after the webinar. We also encourage you to ask questions via the chat, and we'll have a dedicated Q&A at the end of the session. As our training concludes as well, I would just really ask that you could please complete our evaluation if you can. It's tremendously useful to help us continue to improve the quality of our trainings. Lastly, as always, I am pleased to introduce today's speaker, Dr. Verna Little. Dr. Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the chief operations officer and co-founder of Zero Overdose, as well as a member of ACU's advisory council. She's a national expert in suicide prevention, a faculty member for Zero Suicide, and previously served for over 2 decades as a senior vice president for a large FQHC network in New York. We're excited to have her with us presenting today, as always. And with that, I will turn it over to Dr. Little to kick us off.
Well, thank you so much. Really glad to be here and really excited to spend the next hour or so with you talking about suicide safer care. And again, as we said, please feel free to put questions in the chat. I actually do watch the chat as we go along. And we'll actually try to stop and answer or weave those in. So please definitely do that. And then we'll leave some time also at the end for some questions. Go ahead. So a couple of things to really think about as we go in. Suicide experiences are not uncommon, right? So it's not a question of if you're caring for people at risk for suicide at all. You absolutely are caring for people at risk for suicide, and particularly people who are thinking about dying by suicide or may have tried to die by suicide. Go ahead. So as we go forward and talk about what to do and how to care for these individuals, because I don't know about you, but I have a master's in social work and a doctorate in psychology, and not once during any of my training did I actually feel like I got very definitive and explicit training around how to care for someone at risk for suicide. And so really wanting to try to have some of those conversations and come away with a different way to think about the individuals who are at risk for suicide that are in your care now or that you will engage going forward. So before we do that, we really want to talk about language. You heard me say die by suicide. We don't use the word committed suicide. People commit crimes, right? Think about the connotation, died by suicide. We also have moved away from language like successful or unsuccessful attempt. When you think about, I can't think about how many people in my career have been introduced to me, here meet so-and-so, she had an unsuccessful attempt. And when we think about what message that sends, I remember one time about an adolescent in the emergency room and the look on someone's face when like you couldn't even die by suicide successfully, or had you been successful, you wouldn't be here. So moving away from that language. The other language that I hear a lot and I see a lot in charts, like people will type it in big letters, patient is manipulative, patient is attention seeking. And I don't know about you, but I've had times in my life where I've had to say, gosh, that wasn't my intent, right? So I don't pretend to know someone else's intent. All I know is that if someone is talking about dying by suicide, they're more likely to die by suicide. So I just start there. And it's more helpful for us to talk about what someone said or did as opposed to trying to know their intent, i.e., they're manipulative or they're intention seeking. And that we want to use words like working, caring for, as opposed to dealing with, as an example, or describing them. Here's somebody who's bipolar, right? Here's a bipolar, here's a borderline, here's a suicidal person. So really thinking about the language. Go ahead. So I think it's important to think about talking about firearms and individuals who die by firearms. So one of the things we know is that many people who die by suicide use a firearm. We know that there's big differences in ages. There's different, it looks different around the country. Like I was recently doing work in New York City. The suicide death by firearm there is less than in other places or in other states. When we look at the age data, it's the 10 to 14-year-olds that have a huge increase or larger numbers of dying by suicide by gun. And then the numbers decrease sort of throughout life, and then they dramatically increase again in the geriatric population. So a little something to know, that 10 to 14-year-old range is actually some of the highest rates of suicide by firearm. Go ahead. So when we think about maternal suicide, we've learned a lot about maternal suicide. We learned that, about 20% of the maternal deaths are actually suicide. That's a pretty high number when you think about 1 in 5, right? We're also learning about when it happens, that it actually happens much quicker than we initially thought. So oftentimes by the time we have someone back for their 6-week follow-up, we may have already lost them to suicide. So really thinking about what that looks like. And oftentimes we might ask prenatal, but we don't ask as much postpartum. And so really remembering to do that and understanding that you really need to ask at some pretty frequent cadences. Go ahead. So go ahead. When we think about youth suicide, I never really thought that I would use youth and suicide in the sentence as much, together as much as I do now. It's actually pretty shocking, the number of 10 to 14-year-olds and even younger that are dying by suicide. If you asked NIMH or some of the others, they would say, really, you should be screening 10 and up pretty routinely for suicide. It's one of the top causes of death. And very lethal. So firearms, hanging, jumping from buildings. And when we think about the number of people that we're going to lose to suicide, it's pretty incredible. And when we look at some of the numbers, it's about 20% of the adolescents that are going to seriously consider suicide. So if you're caring for adolescents and you don't have as many identified as being at risk, then you're likely missing a lot. Go ahead. So when we think about what some of the numbers are, we talked about the 20%, but think about the 10.2% that are going to try to die by suicide. And I always like to put this in perspective and think about a high school classroom. And if 10% of them are going to try to die by suicide, how many classrooms are in that hallway? How many hallways are in that school? And how many schools are in just one community? And so really starting to think about what that looks like. I recently started a project in Montana getting referrals for behavioral health services for adolescents, and 36% of the kids referred in the first month were either at risk or high risk for suicide. And so those are some pretty incredible numbers, and that's not different than what we're seeing in places around the country. Go ahead. So geriatric to me, interestingly, oftentimes, particularly in primary care, geriatric patients don't even get referred because it's kind of like, well, of course they're sad. They're old, right? Of course they're sad. And so what we really need to remember is that they actually do make up a significant percentage of the suicides, and that, you know, not everybody who's older is sad or at risk for suicide. One of the greatest risks for someone, for a senior, is actually losing a spouse or partner. That actually puts them at the greatest risk for suicide. So something to kind of keep in mind as we go forward. Go ahead. If you haven't been to the Zero Suicide website, please go. There's lots of information that I think you might find helpful there, particularly for organizational, and there's some individual trainings. Go ahead. So definitely worthwhile to take a look there and see. So a couple of things to really think about. You know, we've heard as we've kind of gone around the country doing this work is I don't actually know what to do, right? And we talked about the fact like I never got any training. And so one of the things I think it's helpful to really think about is probably you can think about a time in your life when you told someone something that you weren't really sure you should say out loud, or maybe it's the first time you said it out loud. And the first couple of seconds after you told someone, you knew pretty quickly, you had like a, oh shoot moment, I shouldn't have said anything, or this was a good idea, I feel better already. And so when you think about somebody at risk for suicide who may not have ever told anyone before, that initial response, that initial first couple of seconds is actually incredibly important. And so what we've started to think about doing, and what a lot of people find helpful, is to do something that I call storage statements. And storage statements are things that we think about ahead of time so that when someone tells us they're at risk for suicide, we're not caught off guard. Because sometimes we are. Sometimes it's the last thing that we say, or sometimes it's, you know, when we're driving our kids to soccer practice, or at the dinner table or the lunch table, or in a break room, or, you know, with a patient just as they're leaving, or that you pass by. And so it's really helpful to think about what we might say ahead of time. And so just 2 or 3 sentences that will really help us to have a response that we've thought about in advance. And we can throw some things in the chat here, but when I think about what do I want someone to know who just told me they were thinking about suicide, the first thing I want to let them know is, I heard you. Thank you for telling me you're thinking about suicide. And I say suicide. Thank you for telling me you're thinking about suicide. I want them to know they're important to me. Your life is very important to me. I want them to know that I have hope for them. And I think that's the really important piece here, is to have those things ahead of time so that you have them and you can use them and say them, and then you can kind of go on to get other information. A lot of times I have behavioral health providers say, well, do they have a plan? Do they have, but your very first initial responses really need to be, hey, thanks for telling me. I heard you, right? You know, your life is really important to me. So oftentimes people will say, you know what, Verna, I didn't do your homework. You know, I tell people, you know, maybe at a staff meeting, at the dinner table, you know, tonight when you're brushing your teeth, think about 2 or 3 sentences that you could say so you have those storage statements. And I've had so many people tell me, like, you know what, I didn't do my homework, but I was really glad that I remembered your storage statement. So really encourage you to practice, to think about it, to have them so that they're there when you need them. I would also say for behavioral health providers, it's really important to talk to people about suicide pretty early on in your initial discussion. And a lot of times what I hear from behavioral health providers is, I had to get all this biopsychosocial information, I had to get all this information, and then at the very end, I find out they're suicidal, and then I have to do all this other stuff. And I think it's important to maybe ask right from the beginning. And sometimes I'll even acknowledge, listen, I know that you and I are just getting to know each other. Like we've just met. And you're telling me about some of the struggles that you're going through, and I just want to ask you, because sometimes when people are going through struggles like you are, they start to think about suicide. And I'm wondering if you're thinking about suicide, right? So that we're asking pretty clearly and pretty directly, sort of from the beginning. And then that session, that conversation, that interaction really becomes about the suicide and about the suicide risk. Go ahead. So a couple of things, for your storage statement so that you don't panic, right? You want to reflect. We really want to say suicide. I hear so many people say, well, are you okay? Do you feel like hurting yourself? We want to be really clear, because maybe hurting myself is cutting, right? Maybe we're not talking about the same thing. And so we really want to, and also if we don't use the word suicide and we don't say suicide and we don't bring suicide into the room, then we're not really creating a space where we can talk about suicide and have open and honest conversations around suicide. Go ahead. So when we think about what we want to know, right, and we think about identifying people at risk, again, say what you want to know. I've had so many people where, like working in family violence, which is where I started, people would ask, well, I asked them if they were okay or if everything was okay at home. But what we really want to know, does anybody hit or hurt you at home, right? So be really clear asking about suicide. The other thing that's important to know, and is so different from how I was trained, many people who die by suicide don't have a mental illness at the time of death. It's these social determinants. The housing, the relationships, the food insecurity, the financial problems, those are huge drivers for suicide and suicide risk. And oftentimes we spend a lot of time screening and thinking about patients who have depression, but many people who die by suicide don't have depression. Like anxiety is a huge risk factor for suicide. Many people who die by suicide don't have major depression, and many people with major depression aren't suicidal. So really broadening what your thoughts are in terms of who's at risk. Certainly substance use and alcohol play a role, but also transitions. And oftentimes we know that somebody coming out of the hospital is at way greater risk for suicide. But that's actually not the only transition that puts people at risk for suicide. Let's take right now, we're in the end of summer. A lot of students, adolescents, children have gone back to school or going back to school. That's a transition. And if you're in a situation where there's bullying, which is a huge risk factor for suicide, then the transition of going back to school actually puts a lot of kids at risk for suicide. So it's not just transitioning out of the hospital. It's foster care, it's a geographic move, it's incarceration, it's physical rehab, right? It's substance abuse treatment. And so really thinking about transitions and being very intentional about asking people about their risk during any transition. Go ahead. So when we think about populations, a couple of this, how many people are at risk on your caseload? And this is really important information and something that you really need to know. So one of the things is, we live in a world where there's a code for everything. Like right now I'm sitting in South Carolina, and if I went outside and a bat fell on my head, right, there's the ICD-10 code for it. And so if you ever, get bored one day, you can look through the ICD-10 book and, your water skis catch on fire, all these things, right? There's codes. And so there are codes for suicide risk. And they're in all of the EMRs, and they should be going on your active clinical diagnosis list, your problem list. That is incredibly important. It's incredibly important for a couple of reasons. One is because then we know how many people we have at risk for suicide on your caseload in the organization. Also, it's a quality issue. If I'm covering for you, if you win a trip and you go to Tahiti for a couple of weeks and I'm covering for you, I'm going to do something different if I see that someone's at risk for suicide, ask different questions, maybe follow up in different ways or a different cadence, right? And also, we want to make sure it's there because we want to make sure that we do something different every time. I need to ask somebody if they're safe every time, right? I need to follow up on that. And if it's on a problem list, then I can resolve it, right? It doesn't need to stay there forever, just like other diagnoses, perhaps. Like we can resolve them, or they're not on that active diagnosis or problem list. And oftentimes, behavioral health providers will say to me, well, I don't want to put suicide on the problem list, or I don't think my patients would want suicide on the problem list. And I would say it's really not good to have a discussion about leaving a life-threatening diagnosis off of an active problem list or diagnosis list. Also, if someone is at risk for suicide, you should be actively treating the suicide risk. Like we used to think, oh, I'm going to treat the anxiety and hope the suicide gets better. Now it should be, suicide should be on your problem list. It should be number one on your treatment plan and number one of what you're treating in your documentation, right? And so you really need to make sure that all of those pieces are there and that you're really making sure that you're covering all of your bases and putting that in there. And what I would say is people don't actually mind if you say, you know, I'm really glad that you talked to me about your thoughts of suicide today. I noted in your chart because I want to make sure that every time I talk to you, or someone from the site or my team talks to you, or I see you, or someone from the team sees you, that we make sure you're safe. And so having those conversations are really different, and people are actually really glad that you care enough about them to make sure they're safe and to put a system in to make sure that they're safe. Go ahead. So we've talked a little bit about, you know, screening and depression screening. So a couple of thoughts. Most of you are familiar with the PHQ-9. On the bottom of the PHQ-9A here, the version for adolescents, you're going to see some very specific questions on suicide, and we'll talk about what those are. But that's because it is really important to be screening, particularly the 10 to 14-year-old population, and asking very directly about suicide. And so the same with adults. We know that question 9, have you had thoughts that you would be better off dead or hurting yourself in some way? We know that asking that question is better than nothing. However, it shouldn't be the only way that you screen or ask people about suicide. We know that people who answer yes to question 9 are more likely to die by suicide. We also know that if you ask and screen people for suicide, that a lot of people won't answer yes to question 9, but will score positive on a suicide screener. So really important information to think about. But what I do when someone, you know, does a PHQ-9 as an example, I will actually say, so it looks like you're having trouble sleeping, and that's a problem for you, you know, most days. And it looks like you're having some difficulty concentrating, like watching TV and the newspaper. And that's a problem for you most days. So it definitely sounds like we need to think about your sleep. Maybe we talk to your provider, we talk about, you know, some things that you might be able to do to help you sleep. And I also see that you have thoughts that you would be better off dead or hurting yourself in some way. And that's a problem for you, you know, nearly every day. Thank you so much for telling me you're thinking about suicide. Your life is really important to me. What I'd like to do is start with your thoughts of suicide and just ask you some additional questions so that you're moving right from that PHQ into having an additional conversation about their risk for suicide. Go ahead. So this is called the ASQ. It is the tool that was on the bottom of the adolescent depression screen, the PHQ-A in the prior slide. I like this tool a lot. It's actually on the NIMH website. I like it because it's short. I think it is better researched and easier to use for children and adolescents. And I like question 5, which is simply, are you thinking about killing yourself right now? Right? Then I know what to do with that information. It also has a really nice script for parents and guardians. And then it also has a script for nursing. Like if somebody calls in, it has some guidance and some things to do. So really helpful. If you're not familiar with this tool, then I would definitely look it up, and it might be something that you could use in your practice. Go ahead. So when we think about an alternate level of care or the emergency room, there's a huge misconception that, like I used to write, patient has suicidal ideation and a plan, and off you would go. That was terrible care, right? Like I just didn't know then. And so we've really learned a lot. And one of the things we know that our role is to make sure people get the appropriate level of care. And we know that if we send people to the emergency room for suicide risk who don't need to be there, we actually put them at more risk. Like there's some research out there that supports that. And as someone that worked in an emergency room for 17 years, I can say there's zero magic that happens in an emergency room. Oftentimes people would get sent to me and I thought, I'm going to ask the same questions and use the same tool that someone in the field could have used who knows this patient. And so also you don't change your liability. People think, well, if I send someone to the emergency room, but the best thing you can do is use some of the evidence-based practices we're going to talk about and follow a pathway and a process, and that's going to be the most helpful for you. Go ahead. So thinking about assessing, we've learned a lot about assessing risk and really understanding risk, and we have the tools to be able to do this. Many of you are familiar with them, but we're going to perhaps talk about them a little bit different. Go ahead. So this is the Columbia scale, and quite honestly, this is the short version, and this really is the only version that I think you need for the most part. There's a new child and adolescent one out, so if you haven't seen it, that is certainly out now and available to be able to use, although it's not in most of the EMRs yet. So when we think about risk and we think about using the Columbia scale, I like this tool because it is actually with different colors. So we have our yellow, orange, and our red patients. So one of the things we know is I can think about suicide. And I could know how I would die by suicide. But do I intend to carry out this plan, right? Do I have intent? And those are questions 4, 5, and 6, right? Really asking me very specifically about intent. I often tell a story because I just think it's a really good example. I had a gentleman one time who was sent to me by the primary care provider, and he had answered yes for suicide. And I asked him, I said, yeah, I think about suicide. And I said, well, and he said, well, I would jump off the Mid-Hudson walkway. And if any of you have ever been to Poughkeepsie, New York, and there's no reason to go there if you haven't been there, but I did live there for a while. And there's a walkway that goes over the Hudson River that used to be a railway bridge. And he said, yeah. And he proceeded to tell me, I know where I would jump. He said to me, they put a fence up, so you can't jump from the middle anymore. And I said, yeah, and they put a phone there in case you're not feeling safe. And he said, and I don't want to land in someone's yard. I wouldn't want to do that to someone. And I don't want to land on the highway or the railroad tracks. So he knew exactly where he would jump. And I said, do you intend to jump off the Mid-Hudson Railway today? And he said, no. That in fact, I'm kind of late for work because I've had to talk to you. Like I have a girlfriend, no, I don't intend to jump off the Mid-Hudson walkway today. And it was interesting because he did think about suicide and he knew exactly how he would die by suicide, a plan right down to the T, like where he would stand. But he didn't intend to die. And so when we think about risk, that's really where the risk comes in. Go ahead. And we want to think about weighing risk with something and a term that a lot of you are probably familiar with, which is protective factors, right? And I ask people very clearly, what are reasons you wouldn't die by suicide today? Because people have thought about like why they wouldn't die, right? Like that's something people have thought about. And then they'll often tell me, like particularly healthcare workers will say their job or their patients, religion, a lot of people with their pets. And I say, yeah, you sounds like you're really, your pet is really important to you and they need you. You're the only one that they have. Family or kids, yes, your children absolutely need their mother, right? I try to reinforce it. And I think of it like a seesaw. So if I have risk, meaning that I have intent, and I don't have reasons for living, that's somebody that we're really going to worry about. If I don't have intent and I have reasons for living, that's somebody who we're going to be less worried about. And so you kind of weigh them back and forth. And I am, again, really clear about asking people, because people have absolutely thought about reasons for living. Go ahead. And sometimes it's important to think about, I had someone not that long ago, and he had a plan and he intended, he said, yeah, I actually do intend to die. He's like, I don't know if I'm going to die today. And he said, but I do intend to hang myself. And I said, well, what are some of the reasons that you wouldn't die by suicide today? What are some of the reasons you wouldn't hang yourself today? And he said, he thought about it. And he even said, like, I thought about this. And he said, my parents have a lot of other children. I don't think, I'm quite critical, I wouldn't really be missed. I don't like school. I don't have friends and I get picked on. And I have years of school to go. And so he didn't really have reasons for living. And I asked him, a little bit. And so that was someone that was concerning for me, right? Because he had intent and he didn't have reasons for living. And so thinking about weighing that is kind of how we help. And a lot of times behavioral health providers will ask me, well, how do I document? It's really important to document your thought process. I document that someone said to me, yes, I have a plan, right? Like if we talk about that gentleman on the railway bridge, I documented all of that. And I documented that he said he didn't have intent. And I documented his reasons for living, so that my decision process, oftentimes we think, well, we did not send person to the emergency room because they didn't have, a plan. But there were some things that did worry you. What were they? And what were your considerations? What did you sort of weigh back and forth? It's important to really document that decision process. And then also to think about safety planning. So we used to do something, right? Some of you may remember contracting for safety, which, wasn't safe and we shouldn't have been doing it. Now we've moved to safety planning. Go ahead. And so safety planning is actually a clinical intervention. And I think that's the important thing to remember. It's not just something we're going to check the box on, right? It's an actual clinical intervention. And so there's some things that we want to do very specifically, like for a yellow patient or for anyone across the board, we want to make sure that they have the lifeline. The lifeline is evidence-based. It's been shown to be more effective than mental health treatment. Most of the lifeline calls are resolved in one call. And what I do is I have them pull out their phone. I have them program it in and I have them call. Why don't you give them a call? I'll be right back. So that they have it, it's in their phone, and they know what happens when they call. And taking those extra steps is really important. Next slide. I also do the Now Matters Now website, evidence-based, shown to reduce suicidal thoughts and behaviors. I have them pull it up. I have them look at it. I have it save it on their phone. I have them use it on a tablet or a laptop. Why don't you look through the site? I'll be right back. Take some time, right? Or let's look through it together. And so now, particularly your yellow patients, your yellow and orange patients, you have 2 evidence-based interventions available 24 hours a day that you can give to someone. Because not everybody needs a full safety plan. Go ahead. I will also give the Suicide is Different website because it's really helpful for parents or guardians or other people in someone's lives. And now they actually get a follow-up phone call So really nice website to be able to give and to use for people. Go ahead. So we all know that risk can change. And we also know that some people are at lower risk and may not need a full safety plan. So let's say, you know, I'm old now, but let's just say when I was 16, I tried to die by suicide and I was in the hospital. But now I'm not at risk now, right? I don't think about suicide. I don't plan for suicide, but I'm still more at risk my whole life. But I don't need a full safety plan. So there are people, maybe are yellow patients, people who are at low risk, maybe have a historical risk, that need to have some basic information to be able to stay safe. I also use this for people who are on emotional fire as well. So as an example, all of you, if I were to ask you, if we were in a room together and I were to ask you and I were to say, if you caught on physical fire, what would you do, right? And you would say, well, I would stop, drop, and roll, right? And so you know what to do if you catch on physical fire, even though the likelihood that you're going to catch on physical fire is low. Well, now I want you to know what to do if you catch on emotional fire. Even though the likelihood that you're going to catch on emotional fire is higher than catching on physical fire, but I want you to know what to do, right? So here's information. This is actually on the Now Matters Now website. You can print it out for people. And it turns out a lot of the same things work. If I stop, drop, and roll, what am I not doing? I'm not dying by suicide. I'm splashing cold water on my face, right? For those of you who have done some DBT, that actually reduces and interrupts those repetitive thoughts. I'm going to look in someone's eyes on my phone, in person, a picture. And so those things are really helpful for me. I also will use it at times to do some family safety planning. So I describe it to people, particularly, maybe adolescents who aren't always the most communicative creatures, and say, okay, a 10 is you are on emotional fire, like you are at the most risk you could possibly be. And, when someone is on emotional fire or physical fire, you can't call 911 right away because you have to do something to be able to do that. So when you're on emotional fire, you may not be able to call the lifeline. You have to kind of put the fire out a little bit, right? And so I tell people, okay, so if 10 is like you're on emotional fire, the most emotional fire, high risk you could be. And 1 is like, nope, doing pretty good, right? I'm on the other end of the scale. Then working with people and families to be able to say, to articulate, I'm a 6. And then have activities or responses or things that they can do when someone's a 6. So maybe if I say, I don't always articulate how I'm feeling, but I could put a number, I'm a 4. Maybe we go for a walk together, or we sit and watch a movie together, or we do something distracting. Whereas if I'm a 10, we pull out the ice water and we put our head in some ice water and we stay safe, right? So that you have activities that you've kind of planned out with them to be able to do when they articulate what number. And that's really helpful for parents or other people in someone's life, because then they're like, oh, here's the number, here's where we are, and I know what to do. I have some responses. So that's often really helpful. Go ahead. And this is the safety plan that most of you are probably familiar with. It's in all of the electronic health records. It's called the Stanley and Brown. And safety planning is really important. And again, it's a clinical intervention. Go ahead. And oftentimes when I go and think about safety planning, and I go and review behavioral health providers' safety plans, I actually fail most of them from a quality review. Because safety planning is the session. It's not something we do perfunctory. Go ahead. And there's a couple of places that we often kind of forget to do really comprehensive safety planning. One is oftentimes I see activities like someone is going to go outside, or I saw one the other day, someone was going to go in their backyard and swing, right? Well, when we think about activities, can that activity happen at all times of the day? So if I'm at school, can I go out back and swing? No. In January at 2 o'clock in the morning in the snow, can I go out back and swing? Probably not. So can it happen at all times of the day? Can it happen right away? And can it happen at all times of the year? And if the answer to that is no, then we have to have a backup or a second activity. You can do this at home and this at school. So if you can't go out and swing because the weather's bad or it's the middle of the night, you could go on the Now Matters Now website. The other thing is to be able, oftentimes we list people. And what we really need to do is we need to be calling them at the same time. So, hi, I'm actually sitting with Sarah, and Sarah listed you as someone on her safety plan as someone to call. And then that person can say, that's great, right? Absolutely. Or that person could say, that's great, but it makes me a little nervous. I don't really know what to say or do. And then you can have that conversation. The other thing is somebody could say, well, that's great, but I'm really busy working during the day and I can't pick up the phone, or I don't have minutes all month, or when I go home, I'm out of service. And say, okay, so if they don't pick up, that doesn't mean that they don't care. Call the lifeline, because they're probably working, or maybe they ran out of minutes. So, and also if someone is really high risk, then maybe we say, you know what, also while we're all on the phone together, we're just letting you know that if we're not able to get you, we're going to call Sarah and see if, we can track you down, because we're going to be really worried about you. And be really creative, right? Why is Walmart on a lot of safety plans 24 hours a day, available by public transportation? And I ask people, how can we keep you safe today? If we were going to keep you from dying by suicide today, what would need to happen? And a lot of times I find people do better in the past tense. I don't know why. But if you ask them, what do we need to do? They get a little overwhelmed. But like, what is helpful for you, or what would we have done, then people seem to do a little bit better. Go ahead. So a couple of questions that we often get: what if my patient doesn't want to complete a safety plan? I get this a lot, and a lot of times that's because we've asked. And a lot of times I don't ask necessarily about a safety plan. I say, your life is really important to me, and I'm going to be really concerned about you. I'm wondering if you could just tell me, if we could just take a moment and brainstorm about some things that you're going to do so that you don't die by suicide today. If you don't have time, you really need to make time. If they have a safety plan, review it, revise it. Even if you're sending them to emergency room care, start one anyhow. Start to talk about it. While you're in the emergency room, let's think of some things that you're going to be able to use going forward to be able to keep you safe. Go ahead. So we also want to do lethal means restriction. And this is really temporary, right? So we want to talk to people. This doesn't mean you won't be able to go hunting in the fall. It doesn't mean that you won't be able to use your gun. And given all of the conversations now around firearms and some of the strong feelings, I've learned to change my language. So I actually say, if we were going to keep your gun safe so that it wasn't used for you to die by suicide, what would we need to do? What would need to happen? If we were going to keep your gun safe so that it wasn't used for a reason for which it wasn't intended, what would we need to do? And I think that's an important piece. We're keeping your gun safe. We're not taking your gun. Also, this is what I do for everyone that talks to me about suicide. Go ahead. And so it's important to know the means. The interesting thing about means is that if you can keep me safe from using a gun, I'm not likely to switch means to something else. The other piece to really keep in mind is oftentimes we think about, well, it's the medication that we're prescribing, right? Or that's in from our practice. That actually may not be the case. I ask people, so you've talked to me about suicide and dying by suicide by taking medications. Where would you get the medications? Oh, well, my grandmother died and my aunt kept bags of medications, or there's a CVS down the street. And thinking about, well, what can you do, right? So medication boxes and individual wrapping. Why do I like Amazon Pill Pack, right? Because if I have to open every single pack, I'm much less likely to die by suicide. Gun locks. I can't have a gun, but I can hold ammunition, right? So really thinking about what that looks like so that you're having some of the discussions now. And I've talked to so many people and asked them, and, you know, particularly adolescents, and I'll ask them, you know, so you've talked to us about dying by suicide and using a gun. Where would you get the gun? And it's so interesting to me how so many of them say, well, you know, my parents have gone to such lengths and they've put all the knives away, or they have, you know, taken all the guns out of the house, but like they forgot the one on the mantle and it's loaded, or if they forget that I go to grandpa's house and he has guns everywhere, or my friend that is next door has guns, right? So that it's like really asking people, where would you get the gun? If we were going to keep you from dying by suicide and using a gun, what would we need to do? Where are the guns that you would use, right? So that we're really having a comprehensive conversation. And I've had, you know, people removing guns from 10 homes. We're thinking about it in 10 different places. So something to really think about. Go ahead. So lastly, talking about caring contacts. So caring contacts are something that we send, not with an ask. We don't have an ask. They came out of, you know, Australia, where people would go into the outback and they'd send them a little note, hey, thinking about you. And that actually reduced the suicides because people knew that someone out there cared about them. Go ahead. And so caring contacts are incredibly important. I will send them, you know, like the first time I see someone and just sign it. And it has to be a little bit personal, like you can have it in your EMR and then you sign it, but you make it a little bit personal. And, you know, one of the things that I know is that these kinds of activities give people hope. And hope saves more lives than anything else, because people who have hope don't die by suicide. And you have the opportunity to give someone hope by using the right language, right? By asking someone open and honestly about suicide, by hearing reasons that they want to stay alive or reasons that they might die by suicide, how they might die by suicide, and having those conversations and talking to people and doing some safety planning and giving them resources and going through the resources with them gives people hope. So you have the opportunity to give people hope. Even if you spend 30 minutes with them doing these activities, you've had multiple occasions where you've had the opportunity to give someone hope, and people can leave with hope. And it does not take, you know, I have an example even of a caring contact where, you know, I was out in the community and a woman came up to me and she pulled my caring message out of her purse and said, thank you so much for sending this to me. I carry it with me. It's helpful. And so you have the opportunity to be able to give hope and to provide care for individuals at risk for suicide. Go ahead. So we're going to stop there and we're going to have a couple of minutes for some questions. We actually have some questions in the chat that we've answered a little bit. We can send out the copy of the Child and Adolescent Columbia Scale. Absolutely, that's something that we can do. So we'll give a moment for some questions in the chat. And I will also put the link for those of you who don't have the information or may not get the follow-up. I'll actually put that information in the chat as well so that you have it. We have a question. Knowing that many people who have suicidal ideation do not have a diagnosable mental health challenge, do you have suggestions for how behavioral health clinicians can bill for treatment? Oh, yeah. So suicide is an ICD-10 code. There's DSM also, but you actually you bill for suicide and suicide risk. And it used to be that wasn't a billable code, but it is now. I train primary care providers to do this. Oh, thank you for doing that. Yeah, I would actually say reach out to us. I'd like for you to attend. We do a training, how to help primary care providers identify and treat patients at risk for suicide in a 15-minute primary care visit. And that is the most important thing. How can I do this in a 15-minute primary care visit? And I make a lot of analogies to things they already do. If somebody was coming in and they had asthma, what would you do? You'd get information. Maybe you'd give them a treatment. You'd do some education. How do I use a spacer? Maybe you'd send them to a pulmonologist. You'd use an asthma action plan. You'd assess emotional triggers or physical triggers, right? And so what do you do with suicide, right? Same thing. You stop, you get some information, you put an appropriate plan in place. So very much. And we actually do that training free for primary care organizations. So if you want to set that up, then that would be helpful. You can actually reach out to ACU. Rick could probably put his contact information in there, and people could reach out to him, and we can absolutely set up a time to train your primary care providers. Thank you, Rick. Yeah, we do training for SUD treatment centers. One of the things that I like to actually talk about is overdose safety planning. And what do I do if someone is at risk for overdose and suicide? How do I do a safety plan? What does that look like? ZeroOverdose.org actually does a nice job and has safety planning, and you can reach out. But if you reach out to us, Rick can actually, we can work together and we can put a training for you in place. But that's actually something that we do for sure. Thank you. Great questions. I'm going to have Rick put in the post question survey so that we can make sure everybody takes that. We really do use it to help inform training and all of that. I greatly appreciate everyone's questions and engagement today. You know, this is not easy work, and it does take, you know, time to really be able to sit with someone and talk about suicide. Sometimes it's really scary. You know, and as much experience as I have, there's sometimes when I send people out when I'm like, oh, did I do the right thing? You know, but really weighing out the pros and, you know, talking to people and giving people an opportunity to talk open and honestly about their thoughts of suicide is really helpful for them. Well, thank you, everyone. I appreciate your time today. I loved all the questions, and Rick and I certainly love doing these presentations and getting a chance to talk to all of you. So thank you very much, and may all of you have a wonderful, hopefully a little bit longer weekend this weekend.